Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
Oh, spelunkers, do I have a sweet one for you today. That's right, sweet, as in dextrose type sweet. We're going to talk about glucopuncture. You probably don't even know what that is, so if you have any curiosity at all, you will want to really go down into this cavern of cognizance. My guests today are experts in this domain. In fact, one of them coined the term glucopuncture. James Ferrie is a sports and musculoskeletal podiatrist from Australia. He is dedicated to finding the root cause of pain and providing practical solutions to help his patients live pain-free. I have been following his work for a while now and knew that I had to get him on the show, and I'm certainly not disappointed after this great conversation with him and his colleague, Jan Kersschot. James completed his postgraduate training in ultrasound and fluoroscopy-guided foot and ankle procedures with the Interventional Orthobiologics Foundation in the United States. He's also completed certification in lower extremity musculoskeletal diagnostic ultrasound. James regularly lectures on diagnostic ultrasound and extracorporeal shockwave therapy. He is a specialist instructor of the Swiss Dohler-class shockwave therapy and a clinical instructor of diagnostic ultrasound for Zedu, where he has developed clinical courses. He is also an International Point-of-Care Ultrasound Certification Academy ambassador and has been a consultant within the custom orthotic and 3D printing sectors. Jan Kersschot is a medical doctor practicing in Antwerp, Belgium, and has been practicing and pioneering injection techniques for more than 3 decades now. He has also taught his techniques around the world and is actually the one who coined the term glucopuncture. He's the author of more than 10 clinical case studies about the use of glucopuncture and is the author of the book Glucopuncture. If you have not heard our episodes on hydrodissection, I recommend you catch up with them, as this technique of glucopuncture is a great adjuvant technique to hydrodissections. I think you'll find it very valuable in your practice. Please join us for this very enlightening and really fun conversation I had with James Ferrie and Jan Kersschot. Welcome, everybody, to the show today. I have Dr. James Ferrie and Dr. Jan Kersschot. And did I pronounce that correctly?
Yes,
Dr.
Jan
Kersschot?
That's correct.
Okay.
Yes, thank you.
I took German a long time ago, but I don't remember too many words. I think the only word I remember is Umleitung, which means detour, right?
Yes.
So great. So James, you're from Australia and practice as a musculoskeletal podiatrist. And Jan, you told me you're focused a lot on the musculoskeletal, but really started out family practice. So thanks for coming on the show, and let's talk about this glucopuncture.
Thanks for the invitation, Dr. Barrett.
So how did you guys get together to begin with? I mean, obviously, Australia is a little bit away from Belgium.
I guess it was social media.
Yeah.
I was working in that same space as Jan, so I've been doing prolotherapy, traditional prolotherapy, for probably 10 years, but I'd also started using techniques such as John Liftoff's perineural injection therapy, which I was originally trained by a doctor in South Australia who unfortunately passed away this year, Dr. Margaret Taylor, and she was a bit of a legend in that space in Australia. So when I went to her course, I was quite skeptical initially that what she was doing using some glucose but her practice revolved around that. So I started taking that back into my own practice and on a few patients that had difficult to treat complex conditions in which we weren't making significant progress with conventional therapy. I began to try some of those techniques on those patients and was pretty blown away by the results. And I think our meeting of Jan was really just through social media. Jan had published his book on glucopuncture, and I reached out to him and we were just chatting online. And then I started telling him about some of the cases that I was treating, because after reading his book, I made a few adjustments to my own technique, and probably shifted a little bit more to using more just 5% dextrose in sterile water, as opposed to, and using that as a bit of a first line treatment, and then sometimes progressing to prolotherapy for other conditions. So then, we were just talking about a case, and Jan mentioned that it'd be really good to write that up. And I think we got a few others to write up as well. But that was really, and then that relationship just started from there, even though we're on opposite ends of the world.
Right. Well, we kind of have the big triangle over the globe tonight, with Belgium and Georgia and Australia. So, and I'm honored that you guys would, take the time, all these different time zones to come on. But I think what we have to talk about is so fascinating. And I think it's going to have a big reach because, we're always looking for another bullet in our armamentarium to treat some of these very complex and especially neuropathic pain. I wanted to do some housekeeping just before we get started as far as the difference between dextrose and glucose, because I get asked this all the time. And dextrose is just an isomer of glucose with the D-rotation. So when you talk about glucose and dextrose, they're really interchangeable terms. And although I know
absolutely,
I know that they may use glucose more in Europe. I don't know. What about Australia, James? Are they?
So we have both. I use for traditional prolotherapy, I use glucose. So I get a 50% ampule and then dilute it to usually down to 12.5% as a starting point, and then titrate up depending on the response I get in the patient. But for the sort of glucopuncture, it's hard to get 5% glucose. It often comes as 5% dextrose.
Right. And it makes no difference as far as the physiological action and what you guys have experienced, correct?
Yeah, correct.
Absolutely. Yeah.
Okay. Because I've been using D5W for hydrodissection for a few years, and it seems to be very good. I think, Jan, you were talking about your experiences in prolotherapy. That's a higher concentration. I remember I took some prolotherapy way back, and I think they were using 30% dextrose or something like that. I don't remember exactly what the concentration was, but it was a much higher concentration.
It depends a bit on what school you're following, but let's say it's hypertonic. It's a solution above the 12%, usually between 12.5 and 25, because in the United States, a lot of the ampoules that came at the time were 50%, and they were diluted 50-50 with the local anesthetic or adding some other products. But the prolotherapy usually was like 12.5. And I started with using 12.5 and even more, a bit in a sort of experimental phase. And I must say that the hypertonic solutions work very, very well when dealing with weakened ligaments, weakened bands, or when you want to make the ligaments stronger and even thicker. And I think that has to do directly with the fact that it's a hypertonic solution, that you create a reaction. That is what you want, what you evoke. By giving something hypertonic, it will lead to some sort of cell destruction because of the high pressure on the cell. It shrinks to such an extent that the membrane will collapse, that the substances of the membrane and also the intracellular substances will come into the extracellular matrix, which is seen or regarded by the body as, let's say, foreign or unusual material in the extracellular matrix, leading to a reaction phase, an inflammatory response, and this inflammatory response will lead to the let's say healing process that we want to evoke. I think this is quite typical for prolotherapy, and in the earlier days, I have never used them. They even used products like this. Phenol or sclerosing products, PGE2. I have never used that one. It's a typical American product. I've never used it, but they were like really almost like sclerosing products, especially in the old days, the 60s and the 70s of last century. They all switched to the dextrose, I think, because of safety reasons. And of course, dextrose is a safe product, or glucose, but you have to add local anesthetics because it's very painful. I always test these treatments on myself, being a patient, or even testing it on myself. So I injected myself during the course and also afterwards when I returned to my office on myself by injecting my thigh or my knee or my toe or whatever where I could put my hands on. And I thought and I experienced rather that injecting these hypertonic solutions are very painful. And I think it's because of the cell destruction that you create locally.
So let me make a clarification for the audience, because we're talking about two different things with prolotherapy and perineural therapy. It's very, very important that there's no confusion here, because the last thing you want to do is be putting a high ice or a hypertonic near a nerve that you're trying to calm down. So I just wanted to make that distinction so no one in the audience confuses that, and they come back and say, well, I tried that 12.5% dextrose on the, sciatic nerve and it didn't work out so well. It's like, it
depends. I've been trying this as well. In the early days that I just followed the prolotherapy course from Patterson, a great teacher, by the way, and Cavallino from Italy as well. I must say that the hypertonic solutions were sometimes very, very effective. And it's tempting because you have patients that have been trying many different techniques, and this was new to me. I didn't believe in dextrose or glucose. I thought it was a placebo effect or whatever, like most of us do in the beginning. But I saw the results. I tested on myself. I used a few difficult cases and I saw the results. So it is effective. And there have been some studies also from prolotherapy from, let's say, the last 10, 20 years, which confirmed that. But I also noticed when I started to dilute and or even use the 5% glucose or dextrose, that it was effective as well, in a different way, which was not clear for me at that time. But I was like also confused because everybody started to call it prolotherapy, because prolotherapy was like, if it's glucose or dextrose, it's prolotherapy, right? But then I thought, if these guys, I saw a few studies of isotonic sugar water, like 5%, in fact, it's 6%, but let's say almost isotonic. They also had great results, maybe in a bit different way, but they had results. So I thought, if it's not hypertonic, the old sort of story of evoking an inflammatory response and consecutive healing because of the hypertonic solution, that's not working now. So it must be the glucose itself, almost chemical effect of the glucose. And that is why I came up with the word glucopuncture, to make it clear to my patients, to make it clear to my colleagues, this is not old school prolotherapy. And it may not work, it may not, I don't know if people are going to pick it up, but I think there's a great distinction between hypertonic and isotonic.
Well, I think that's an important thing. And I mean, obviously, if you're putting it in an anatomical space like an Achilles tendon or something where you do want to create a response, that's going to be a lot different than maybe the mechanisms that we want to see on peripheral nerves. And, I think there's a fair amount of data. I think we should talk about the mechanism of action. And I pulled one of your articles where you were talking about low back pain, and you delineated all of the different the physiological mechanisms, which I thought was very good. There were a couple that I really hadn't thought about, but, I think we know that D5W or dextrose 5% or glucose 5% seems to affect the TRPV1 vanilloid channel and kind of shut down some of the hyper sensitivity in the neuron itself. One of the things that you pointed out in your article was maybe the increase in ATP production, that may be, part of it as well. So you want to expand on that a little bit? Because I think that's important.
Let's say, that's quite hypothetical. And I'm hoping that someone who is more expert in this field, because I am not, I'm just looking at other articles and books and things I know from my medical education and try to figure out how does this glucose work then? If the hypertonic solution, if that theory is put aside, we just are left with the glucose or dextrose, and that's it. And where do we inject it? Not IV, as it is meant to be, because we are applying it off-label. We are injecting it into muscle, into skin, into tendons, near tendons, into joints, wherever you want, and where we can inject it near nerves. If you use ultrasound, you can go right next to the nerve, do a hydrodissection and so forth. So what is this glucose doing in these tissues? What's going on? And doing some sort of research on glucose, I thought, well, yes, glucose, that means energy. And what's energy? It's ATP. And adenosine triphosphate is a very important product. I even found that Japanese, many years ago, found that ATP was directly involved in pain processes. I don't remember the details. It's all in the articles and in the book. But I thought, we haven't been taught about this for all these decades, and it's an important product. And I still don't know who was the first to really use the dextrose 5%. I found one article from a Korean guy, Dr. Kim. I tried to contact him, but I never succeeded because only the summary of his article was in English, the rest was in Korean. And he did a study where he compared sodium chloride, 0.9%, dextrose, and a local anesthetic. I think it was procaine or lidocaine for myofascial trigger points. And I like a lot myofascial trigger points. It's also one of my, in my daily practice, I see so many beautiful things by just injecting to myofascial trigger points. And he did that study. And of those three, I would expect that the local anesthetic was the best, because that's what I was using. I learned to use procaine or lidocaine for myofascial trigger points, according to Trevor and Simons, the American doctors who invented or first described this theory. And he found out that the glucose or dextrose 5% was better. And that was like, what?
Right.
No, this can't be true. No. Glucose is a placebo. Procaine is a local anesthetic. It really works. If you inject it, you can use it for a dentist. It's the same thing. So that was like, whoa, a big eye opener for me. And then you start to do some research. You find about the prolotherapy. You also see other techniques using similar ideas. But I'm still not sort of sure how it really, really works. And I think at this moment, as we speak right now, in Asia, in America, in Australia, in Europe, people are looking and doing scientific research to find out how does it work, because we seem to know clinically that it works. And we have some hypotheses, but we're not there yet, I think. I don't know about you, James, or Stephen, how you feel about the idea, finding out how it really works.
There's some interesting research. There's a journal from '92 by McIver, where what he did in an experimental model was take from an animal the unmyelinated C fibers and expose them to different conditions. And what he was able to do reliably was he would create a hypoxic environment using nitrogen, or use a hypoglycemic environment using an isomer of glucose that wasn't sort of biologically available to the cell. And what he showed is the combination of hypoxia and hypoglycemia at the cellular level at the C fiber will increase the frequency of depolarization by 700%. And that you could reverse that effect by just giving glucose and some oxygen back to the cell. Wow. But what was more potent was the glucose was more important than even the hypoxia. And I think we also know that when people have a chronic pain condition, they often stop moving. And we also know from the research as well that when people stop moving or are immobilized, even for a short period of time, you get an increase in proliferation of the loose connective tissue. So on an electron microscope, it almost looks like an overgrown forest. And you also get a decreased density in the capillary density decreases as well. So if someone does have some scar tissue adhesions, whether it's post-operative or post-injury, or even just for prolonged immobilization. I think we could potentially be creating an environment in where we are getting a bit of a hypoxic or a hypoglycemic environment there. And plus, it's also going to affect the ability of fascia to slide, which is, particularly important for sensitivity of those pain sensitizing nerves as well. So that was a really interesting study I found in terms of in an animal model being able to reliably, effectively switch on. And they were more sensitive to the hypoxic and hypoglycemic environment compared even with an acidic environment where they use lactic acid. That didn't increase the frequency of depolarization quite as much. So I found that particularly interesting. And then there's also work in terms of the tandem pore potassium receptor, where glucose or dextrose on the extracellular environment is able to interact with that pore. And what it does is it leaks potassium out of the cell membrane. So it has an effect where it hyperpolarizes the cell. So the threshold to reach action potential is larger. So this, I think, is particularly helpful and potentially explains some of the immediate effect that we see. Like just yesterday in clinical practice, I had a patient who was a professor of medicine, and she'd just returned from an overseas trip. She'd had some degenerative knee osteoarthritis that had really flared up, really sensitive, really tender just with light touch, nocturnal pain. And her foot problem that she was seeing me for had otherwise resolved. So she's like, oh, it's more my knee that I'm limping for now. So I did offer to her, look, there's a technique that I can use where all I used was subcutaneously, I injected with a 27 gauge needle, very superficially in the tender areas. She was very skeptical, but she was in pain and it had not responded to paracetamol or NSAIDs. And within 5 minutes, the burning had stopped. The tenderness on the sensitivity and that local sensitization had resolved. And she walked out of there without the limp. And she was quite blown away. The fact that she kept asking me, are you sure you didn't put anesthetic in that? That was just glucose.
Yes, of course, yes.
Right.
Nobody would believe you, would.
Yeah. I think you guys make a couple of really important comments here. One, I see this glucopuncture as a great adjunct to hydrodissection, because the comment that you made, Jan, was you can put this around the very small nerve endings, stuff that you're not ever going to see even on ultrasound, within the muscular structures themselves, or in the fascia, these types of things. So I see where you could combine both of these very, very well. Let's circle back just a little bit, because I'm trying to wrap my head on the mechanism a little bit, but I don't think there's any neurological condition that does not have a component of neuroinflammation. And so undoubtedly the D5W or glucose 5 has an anti-inflammatory effect. But the other thing is, and James, you mentioned this very well, a lot of times these nerves are in hypoxic environments. And so if they're hypoxic, they're probably not getting the amount of intracellular or intraneural glucose that they really need. So now all of a sudden you put this right next to the nerve and it gets a load of energy, so to speak. And we know that, it's going to go through the Krebs cycle. It's going to create ATP. And so maybe there's, the combination of the neuro anti-inflammatory as well as just the energy component.
And I think even that hypoxic environment, something that you've published on, Stephen, and talked at with the Phoenix sign, using a small amount of local anesthetic to increase that vasodilation of the blood supply to the nerve, and having a reversal in some of that sort of neuropathic pain and increase in function. So it certainly is. And I think there are times I also like hydrodissection. I think it's a really valuable technique, and I use D5W for that as well. But there are certain circumstances in areas where the nerves have branched to such a complexity where that's just not possible. Right. So we know that if we're injecting in those tender regions, partly we're causing we're opening that fascial plane up a little bit. We are causing a bit of local hydrodissection, which may improve the tissue sliding, but also address some of the metabolic disturbances that may have arisen because of adhesions or fibrosis or scar tissue around some of those smaller nerve endings where it's a bit difficult to properly hydrodissect, where you don't have a specific lesion of, say, a tibial nerve or a median nerve or something like that.
Right. No, I totally agree. And, that's why I think the combination, I mean, if you have let's say the case example that you had in your paper that I pulled the lateral ankle pain.
Yep.
And in that area, the sural nerve has so many little aberrant branches that you're not going to get what you need probably from a hydrodissection, simply because it's more than just the main branch of that nerve. And so, I mean, yes. I think, Jan, you talked about trigger points. Okay.
Yes.
So a lot of times the trigger point really isn't, I mean, some people can say they can palpate them really well, like massage therapists, that type of thing. I don't have, my thumb isn't that good, but
you never practiced enough.
Yeah, exactly. Right. I got to take my thumb in for a tune-up, but, talk about that a little bit. How much volume are you putting in these trigger point areas?
Well, it all depends on the area. Let's say I wouldn't only focus on the trigger points, because, for example, in a case like a sprained ankle, and people are sometimes very vague when they point to it. Let's say I'm going to use my hand, and they say, "Where?" And I ask them, "Where do you have pain?" They say, "Oh, it's here," like 10 centimeters, a few inches long, and how broad. They don't know exactly. And then I'm going to look for pain points in the area, which I sometimes find, sometimes I don't. And then I'm going to look outside the area, because the pain can be referred from outside. And a very typical example of that is pain on the anterior side of the patella tendon, the anterior side of a knee. And then you do, someone had done MRI, ultrasound, all is fine, but they still point to the patella tendon region. Bursa is normal, everything is normal. And then I just go up around the corner, so to speak, more proximal. And I found typically in many cases, trigger points in the quadriceps muscle. Let's say 1 inch or 2 inches, a few centimeters above the superior border of the patella. I inject there. I'm not touching the patella. I'm not injecting into the knee, not into the joint, anywhere else, not even the pain zone. And after 1, 2, or 3 sessions, depending how serious the case is, the pain is gone. And that's so beautiful about trigger points, not only in muscles, but even in ligaments. And I emphasize that in the book, because not so many doctors worldwide are aware of the importance, in my view, the clinical importance. That is that you inject at a distance. So that is referred pain. But what you were mentioning, Stephen, I think is when you're, for example, with a sprained ankle and it's a local problem which needs local treatment, then we are not talking about trigger points. It is like giving food, energy, glucose to the nerves and to the other soft tissues. And as you said, and I agree with you, and I'm happy you already mentioned it, that these nerves just not like one electrical cable and that's it. No, they're a lot of very fine branches going all over the place. And even with the best ultrasound machine, you can't pinpoint all of them because they're too tiny, and you can't inject all of them separately. And that is why even those doctors who don't use ultrasound seem to have amazing clinical results just by injecting in the area. But what they do is they give multiple injections to the whole area. And that's also how I work, by the way. So, and I've seen so beautiful results, and I thought, oh my God, everybody should know this. This is maybe my optimistic, biased view. I realize that. I haven't done any RCTs yet, only some clinical cases. I hope others will do that for me to confirm my findings. But sometimes I'm like, oh my God, is this really happening? This should be recorded. This should be like out there. And every doctor in the world should know this. And that's why I started to share by just writing one article 2 or 3 years ago, and then another one in an unfamous journal. And And I see now, like talking to both of you, I'm very grateful to both of you that you want to join in this story and share experiences and share with other colleagues and so forth. And I'm sorry, I was deviating from your question because you were talking about distribubles and how much I was injecting, right?
That's fine. I love it when you get on a roll because that's how we get educated, and then if you're not passionate about the stuff you're doing, then you're usually not that great at it, But I love that. But let's go back. So how much volume? Let's say you found a discrete subscapular trigger point. Guy can't move his shoulder. How much are you putting into that? Now that's a nodule that my thumb can feel, but
no, it's difficult to feel. Yeah. Although the infraspinatus, as we call it, infraspinatus muscle is a very common muscle to inject because it's such an important one. It's very easy to put your hand on the shoulder and with your thumb find sensitive spots. It's much easier, I think, Stephen, than you may imagine. But even I would say in the beginning, I would give like 1 or 2 ml of the product in each spot I could find.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. Several years ago, I chose Alpinion as my ultrasound brand of choice after years of experience and research into ultrasound imaging. In fact, I have 2 of their machines. Alpinion has incredible precision and penetration built into their technology that, in my opinion, is simply the best value in all of the ultrasound imaging space. They have several price points to meet your needs, and I can tell you definitively that you'll end up having to pay double to achieve the equivalent imaging quality from other top brands. That doesn't even account for the unlimited software updates and remote tech support included with no monthly fees. Right now, to show their appreciation for the listeners of the Pod of Inquiry, they're offering an incredible discount. Their portable i7 retails for $21,000. But you can get it discounted at most medical meetings for $19,000. But my listeners will get it discounted to $15,900. This has never been offered anywhere for the new portable system with the engine of a console system. Use code SBPOI to take advantage of this incredible offer. You won't be disappointed with Alpinion. I sure haven't been.
Over the years, I have been using even more volume. Because I was a neurotherapist using Procaine, and with Procaine you're limited. If you inject like 5 cc or even 10 cc, then people start to get dizzy and so forth. You don't have that with glucose. There are no limits. Right. Even for diabetics, by the way. We can discuss that later. So I started to use more volume because I thought more ATP in the muscle, all the small the small nerve fibers within that particular muscle. So why not give some more? There is no side effect of it, and it's not even influencing the glycemia or whatever. So I started to inject more, and I would rather say today I would use between 2 and 5 cc for each spot. So this means I'm using a lot of more volume than in the beginning. I'm not sure about you, James, how you work, or you, Stephen, about volume and for each injection, but that's sort of my story for the moment.
Yeah, I think it's hard it depends on the area. You almost get a feel for how much the tissue wants to take. And I'll often find on my first session with somebody, I'll tend to inject a few less places and slightly lower volume and just gauge how they respond to that. And then titrate up from there. And the pain points often change as well. I remember one of the cases that stood out to me, this was when I first started practicing. It would have been in the first 6 months that I'd graduated. I had a man who's diagnosed with complex regional pain syndrome following a ankle sprain. He was an orderly and tripped in the workplace, sprained his ankle. There was no fracture, but he developed chronic pain and quite profound complex regional pain syndrome after that. My understanding of complex regional pain syndrome at the time was that it was primarily driven centrally. basically, once you'd had that inciting event. So in this case, there was no really discrete nerve injury that was located, there was no fracture, and the ankle sprain healed in a reasonably unremarkable fashion. But I did a sural nerve block on him, and it took away all the pain. And that really sort of flew in the face of a little bit of because it sort of had shifted from, once they'd had that diagnosis, the focus being on just the, sensory nervous system. Mm-hmm. And, things like cognitive behavioral therapy, psychology, physical therapy, those sort of things. But that was a case before I was doing these type of injection therapies, but it just highlighted, it was very interesting that I could make his pain go away with a simple sural nerve block. And at the time, I even tried things like, I did some mirror box therapy with him because he had quite a lot of muscle weakness as well. And we made progress, and I don't know whether it was just even the anesthetic injections, but we were doing a combination of some mirror box therapy, plus I was doing a block at the same time. He did make some progress, but I think that really got me interested in, I guess, treating some of the nerves peripherally. And because it had sort of been one of those things that, like, once they've got complex regional pain syndrome, we sort of start to forget about the peripheral nerves and just focus on, and this is something that I'm sure you'd be able to speak to more, Stephen. You'd have much more experience in this area. But it was just an interesting observation when I first started working that it shouldn't have been just related to one nerve path.
Right. Well, and they divide CRPS into CRPS 1 and CRPS 2. Yeah. And really, if you think about it, the majority of CRPS 1 cases are really CRPS 2. It's just that they can't find the injured nerve.
I agree.
Okay. So, I think it's kind of like the word idiopathic. We're all idiots because we can't figure out what the cause of their neuropathy is. But if we look hard enough, a lot of times those idiopathic cases become, there's a named nerve injury or there's XYZ, who knows? I mean, there's a lot of work that has to be done from a detective standpoint, but I think you're spot on. And I'm glad you brought the complex regional pain syndrome up, because I've done hydrodissection on a few patients with CRPS, and we're very cautious with these people. But unfortunately, there's this misguided perception that the CRPS patient should never be touched and all of this. And we know that just isn't the case. I mean, if you can find the nerve injury and treat them appropriately, you can a lot of times eliminate that pain generator that's constantly firing up their CNS, and they can have radical improvement. But if we go back to, let's say it's not CRPS, but let's say they just have a very hypersensitive area. What I've seen with hydrodissection is that a lot of times, let's say they have a painful scar after a surgery or, ankle joint replacement or something like that, and everything's just stuck down and you can't touch their skin. They've got this hypersensitive, area where they can't put a sock on, they can't wear a boot or shoe or anything like that. It's interesting that, and like you mentioned with your physician that you treated for the knee pain, that if you put a fairly decent sized bolus of D5W in there, they may not get a long lasting relief, but they almost always get a temporary relief, which is kind of interesting. To answer your question, Jan, about how much we use, I mean, it just depends on how much I need. I've hydrodissected superficial peroneal nerves where I've used 60 cc's on that nerve.
60?
60, yeah, 60 cc's. Whoa, yeah. And it looks like the anaconda that swallowed the pig. And it's like this big lump. And within 2 hours, it's gone. It's kind of like the body just resorbs it. And they're like, whoa, But, and there you have to wonder, am I getting some response because of the mechanical action? Am I getting that dermis that's scarred down to the deep tissues? Am I freeing that up a little bit? Who knows? I mean, there could even be a little bit of a microscopic denervation phenomena going on there. I don't know. But we've used some pretty high volumes.
Yes, I see. I think my sort of background leads me more to giving multiple injections of smaller volumes than I would rather give like 10 injections of 1 ml or 20 injections of 2 ml in the whole region. But I'm not working with the ultrasound, and I will talk about that later again. But I noticed that even by just following these simple sort of guidelines, the patient pointing you to a specific area, or you looking for pain points or trigger points in the area, or referred pain patterns, already is so effective that I'm wondering if general practitioners, maybe in 5 or 10 years in Europe or elsewhere, will just do this on an everyday basis, just for the common small things like sports injuries. I had a hockey player that I treated along with a physiotherapist, and we're probably going to publish this as well. And she really wanted to play 3 weeks later, but she had a 10 centimeters, 2.5, it's 4 inches long on ultrasound muscle tear. And the doctor from the club, from the hockey club, said, no, you can't play for the next 6 weeks. We treated her 3 times with the glucopuncture, just locally, no ultrasound, just injecting in the area, the painful zone. And she played after 3 weeks perfectly well, without taking any medication at all. And so I think this is so amazing. It's so safe for all these athletes out there who are frustrated that they can't play and want to play and are in pain. And I thought, is it really possible that we are here digging gold? Like, it's inexpensive, it is easy to apply, it is extremely safe for the patient, it's not on any doping list. What more would we want? So I can't keep this for myself. And I think you both feel the same. We have to share this with our colleagues.
Absolutely. Absolutely. Now, let's talk about the treatment, the serial nature of the treatment. Now, obviously, it's going to depend upon the severity of the condition. I get that. But what's the average? I mean, in one of your articles, you mentioned that your first treatment, you usually may not see a great or astounding result, but it needs to, you have some sequential therapy. So can you guys share on that? Yeah.
Oh, yes, Stephen. So thank you that you bring this up for us and for people listening to us. If you compare, for example, glucopuncture with PRP or hyaluronic acid, which is also the same category, no steroids, no suppression of symptoms, inflammation, we notice that we need more sessions. Let's be frank about this. We have had our cases, like 1 or 2 sessions, everything is gone. But on the average, I would say we need 2 or 3, a few times more sessions. And what I say to my patients is, you may have, even if you have knee pain for 6 months, you can walk out here pain-free, but it won't last maybe more than 5 minutes or an hour or a few hours. And I tell them, this is part of what we are doing. We are recharging your batteries. It's like, I don't know, in the old days, we sometimes had to help a friend with an old car. We had to push them from the back so it could run again. You see the picture for you in the old days, as 80s maybe?
Yep.
And I say, this is what we're doing with your local nerves or muscles or inflammation that's going on there. We are recharging your batteries. And that's what glucose is doing, or dextrose. We're not lying to them. It's a good metaphor in a way. And the ATP is indeed a form of energy. And then the engine starts to run, but after a while, it's not used yet to do it on its own energy. It stops again, and then we had to run behind the car and push him again. And that's what we're doing with the next glucopuncture session. And so there are different sort of possibilities here. They have immediate improvement, which is, for example, like James told us about the knee patient, and it could last after 1 session. You also may have a temporary worsening in the beginning. We call it a reaction phase. And it's important that we inform our patients, and so also our colleagues, that this can happen, and it's not a bad sign. Because what we are doing is we are like, it's not like putting the dust under the carpet. We do the opposite. We hold the carpet open, we blow, and it's going to be a lot of dust, but we want to evacuate that. We want to get rid of that. And that may give a worsening, like more swelling, more pain. And then if you haven't explained it to your patient, it's your fault that they say, oh my God, this is bad for me. No more sugar water for me in my knee or my ankle, because it turned out worse instead of better. So there are some different types, and it depends also where you inject. If you inject superficially, like intradermal injections in the area, you usually have like a sort of, not so much of a reaction phase. But if you start to inject deeper, and especially in areas where there has been chronic inflammation for weeks, months, sometimes even years, Then I say to my patients, you're going to hate me for the next hours or tomorrow morning. You're going to hate me. But I tell them, please, this is really for your own good. This is really like a cleaning up, like a sort of local detox. I don't like to use that word, but it's like you bring out the normal mechanisms, the physiological mechanisms, you reactivate them. And that is what on the long term is going to give you real tissue healing. We're not just taking away the pain. We're not just fixing things. It's like an internally, let's say, natural treatment in a way. Like they call it now in orthopedics in the United States and probably also in Australia, regenerative medicine. That's what orthopedic surgeons are using as a term to describe PRP and other similar techniques, which are becoming very popular now. I think we are doing almost the same, but to a lesser degree and much less expensive as well, and very easy to apply.
Well, it's kind of interesting. I probably was the first person in the United States to inject PRP for plantar fascia back in 2001. And,
wow.
And it was a very interesting, I mean, they got better. I mean, there was no doubt about it. So that was kind of early regenerative therapy. But I want to circle into regeneration because I'd like to see if you can differentiate between acute and chronic, because you made a great point about if somebody has a very chronic issue, it may exacerbate it at first and almost like for lack of a better way to put it, like a musculoskeletal Herxheimer reaction. You know, when you're working on somebody with Lyme and, you know, you're ozonating them and all that, you know, sometimes you'll make them worse. So in an acute situation, and I don't know the answer to this, but it seems that like in an athlete, you may be able to reduce the pain with the glucopuncture enough that they could start physiotherapy a little bit more aggressive right away. Sure. And then have to come back. So you're combining them. You're marrying the physiotherapy with the glucopuncture because they couldn't tolerate it otherwise.
That's also a point what you're making. And maybe about the athlete I just mentioned, there's one other thing I want to add regarding using ultrasound for injection or not. In the, say, classical glucopuncture, as I have described in the ebook, we tend to sort of use our eyes and our hands and the patient's reactions. So that lady, she was like maybe 20 or 25. She was lying on my table on her stomach, and I was looking at her hamstring, where she had the pain. And when I was examining her, I found several hard spots or areas which were not tender but hard. You might see them on ultrasound. These were old injuries. I didn't inject them. But when I found hard spots, which are at the same time very sensitive to the touch of my thumb, these were the recent ones. Because she was pointing to the whole area like two hands of just as a surface, like quite a big space. And then you have to inject. And then I really use my finger, my thumb, to identify the painful spots and hard spots. And these are the ones that I inject. And you don't have that when you use the ultrasound. Ultrasound is fantastic when you want to do carpal tunnel, when you want to do hydrodissection. There is no doubt. But for this kind of patients, I love to work just with these two things here. Right. They're for free. And the more you use them, the better they get. You really sort of like someone who's playing the piano. If you play it every day, you can play with your eyes closed, so to speak. And it's a bit the same for glucopuncture. And so I just wanted to mention that in between because I didn't want to forget that. Sorry about that.
No, it's very good. James, you were going to say something.
So the way I tend to approach it, if it's probably more of an acute injury, I'll often start just subcutaneously. And it's almost treating those tender places subcutaneously, which just has an analgesic effect. As you mentioned, walking, if someone's in a really, has a really maladaptive movement pattern, they've got a really antalgic gait, they're limping a lot, you are going to start developing trigger points and muscle spasm in other areas that are compensating for that. So if we can start to reduce some of the local sensitization in that painful area, even with some subcutaneous injections, and you typically, I don't find, they're often a really gentle approach. So even in patients that are really sensitized, with a 27 gauge needle depositing in some of the tender areas, you don't tend to see that same really reaction phase. But then when I'm treating, for example, like a really degenerative, a degenerative plantar fascia, where we've got significant fasciosis, and we see this on ultrasound. So this was ultrasound was a huge eye opener when I started using it. Would be probably about 8-9 years ago now, because you could actually start to grade the pathology. You could see in real time how degenerative that plantar fascia was. Is this something that just is mildly thickened, or do we have something that's very heterogeneous where we've got significant delamination of the tissue? And in those cases, what it started to do, because I was using a lot of shockwave, and I was finding that there are some patients that shockwave works really well for, these chronic plantar fascial patients, and there's other patients that I wasn't getting the same response. And then when I started scanning a lot of these patients, what I was finding is if they had a very, very delaminated plantar fascia, those patients did not respond well to shockwave. So those are the patients that I would shift to using. I originally started as a gateway drug using Prolotherapy, and then also used PRP and autologous conditioned serum and those sort of things. And they're really fantastic tools, but they do have more of you do kick off more of an inflammatory response. So in some patients that are a bit more sensitized, that gentle approach with a 5% dextrose, it really doesn't tend to cause anywhere near, because you'll find the same thing. PRP, there'd be certain patients I would treat, and they'd respond really well, and they'd have, a bit of a mild increase in pain that would otherwise settle down. And probably 1 in 10, you could actually kick off a significant inflammatory response that it would take you a week or so to try and really calm that down again. So in some of the patients, the glucose I found to be pretty helpful, because you could, if you were using just conventional prolotherapy for those patients, you could titrate up you could just titrate up the percentage of glucose to have more of that inflammatory reaction. So if you're dealing with a more degenerative tissue where we want to create a little bit more acute inflammation to restart that healing process, that can be helpful. But then in some of the patients that have a lot of sort of persistent chronic pain, the 5% dextrose is fantastic, because even if they're quite sensitized, they have usually a much lower reaction, and they're willing to come back very frequently for those. They'll come back once a week because of the response they get afterwards. Right.
How many, on average, let's say you have a very thickened fascia, and I'm really glad that you mentioned that, because one of the things that I worked on many, many years ago, and nobody really paid attention to it, was we were able to stage and grade plantar fasciopathy based on how it looked with the ultrasound. And it kind of really pisses me off how everybody, if I asked you, hey, do you want to go hunting tomorrow? And you love to hunt, what would be your first question? Well, what are we going to go hunting for? Because if we're going to go for mouse, we're not going to take an elephant gun. And, so with the ultrasound, it takes all the guesswork out. And I thought you made a really interesting comment that the extracorporeal shockwave therapy didn't seem to do as well with the severely delaminated or degenerative fascias. And so I think it's, again, knowing what beast are we treating today, and I think that's a really good point. But let's go back to just the glucopuncture for plantar fascia. On average, how many times do you think that the average person would come in for an injection before they got relief?
So what I will tend to do with that is I'll start off often with, say, 12.5% glucose with a little bit of lignocaine. I'll also typically do a tibial nerve block at the same time, just because an injection into the plantar fascia is uncomfortable. So I'll typically do a nerve block there. I'll often repeat that every 3 to 4 weeks. And I find on average, I'll tend to do 2 or 3 sessions with patients. So that one, we're using a higher concentration. So you are a bit more likely to cause a flare-up for 24 to 48 hours after, compared to using 5%. But then there are other cases. So that's if I'm dealing with a really degenerative plantar fascia. But like you mentioned as well, ultrasound just really opened my eyes to what I was seeing, because one, I could look at the bony cortex as well. We could look at the fat pad and assess how degenerative the fat pad was.
Right.
We could also see whether we had a really active, so those cases where you've got a lot of delamination and quite advanced fasciosis, they often present to us as like an acute on chronic flare-up in pain. So they might have had some, more typical plantar fascial symptoms, post-static dyskinesia, pain warms up through the day, and then they have this really severe exacerbation, and you almost inevitably find intrasubstance delamination or tearing, and you also see that sort of perifascial edema as well. So those cases, I've found that those cases don't respond very well to extracorporeal shockwave therapy, but they do respond well to often an injection. So yeah, I find that is. But then there are cases where I'll use the 5% dextrose. So if the medial calcaneal nerve is a bit irritated and they might have a bit of neuritis there that's associated with their heel pain, I'll often inject that with D5W. I'll also sometimes inject the trigger points in the abductor hallucis muscle as well, that can often, in cases where they might have a bit of a distal tarsal tunnel starting to develop, not quite a proper distal tarsal tunnel, but when someone has been limping and that abductor hallucis muscle is in spasm, has trigger points in it, that will obviously put some compression on the medial lateral plantar nerves as well that can contribute. So in some cases I'll use in the early phase. So like I had a patient just yesterday. This is a really acute on chronic presentation. She's in a lot of pain. What I'll do in those cases is stabilize their pain first. So I've put her into a tri-lock ankle brace, which I often really like for these patients. I injected because she had some neuritis of that medial calcaneal nerve, so I injected that with subcutaneously with 5% dextrose, and she had a very painful trigger point in the abductor hallucis muscle. I injected that as well, and again, this patient come limping into the room. And in this case, I didn't want to get into treating the actual plantar fascia yet because she's still in a really acute flare. So I want to try and stabilize her symptoms first. But within 10 minutes, she's like, I'm in a lot less pain just with those subtle injections around the medial calcaneal nerve and the trigger point in that abductor hallucis. So the hard thing is that, medicine and health care is a bit of an art, and it is really hard sometimes to completely create protocols that are very strict. So it really depends, I find, on how stable the person's pain is will often determine my approach, and then also the findings that I tend to find on ultrasound as well.
Yeah, I've been trying to stick patients into algorithms for more than 3 decades, and it hasn't worked so well.
It's hard.
But yeah, it's very hard. But gentlemen, this has been an absolutely fascinating discussion.
Yes.
I sense that we're going to have to come back and talk about this some more because there's so much to say, and actually, I think there's a huge demand for this type of care. I think, Jan, one of the things you mentioned was you hope that there would be more, research as far as pathophysiology and mechanisms of action. The problem is that big pharma can't patent glucose, and so there's no economic driver there for it.
I'm aware of that.
Yeah,
yes.
Yeah.
Oh yes.
But, anyhow,
and that's maybe also the reason why maybe you saw that I am sort of realizing that if you do a good RCT, it's a lot of money, right?
Oh yeah.
And nobody's going to invest it. I don't have the money. I'm on my own, and local hospitals are not interested. And so I was thinking this method, because I was teaching other injection techniques before, but also in low-income countries like in Africa, South America, you name it, and sometimes in Russia. And sometimes these doctors came to me and said, "Your products and your technique is great, but for us, this is a lot of money. Your products, they were European products. They had to pay it in euro." They said, "It's too expensive." And now I thought I have a similar technique with a product that they can make on their own, in their own country, much more inexpensive. And I thought that might be a way for me to sort of sneak around this problem and say, if these doctors in those countries are starting to use the glucopuncture because it's easy, accessible, it's inexpensive, they even don't have an ultrasound machine in the area. You have to walk 4 hours before you have a small hospital. Let alone if you can pay for it. I've been in such countries many times. So I thought, and I hope, that glucopuncture could be a sort of way of getting in there and introducing it in these low-income countries, or for low-income patients in high-income cities, because you have poor people in beautiful cities in the world as well. And so that is sort of the one of the reasons why I sort of got there is not just I want to help these people, but also the pharmaceutical industry is not involved. They're not interested in those countries. And maybe we have a chance there. We will see.
Well, gentlemen, thank you so much for taking the time. It was absolutely fascinating, and I learned a lot, and I'm sure the audience will too. So thanks so much.
Thanks for the invitation, Dr. Barrett.
Thank you for having us, Stephen. Very great idea. Thank you so much.
You're welcome. This episode is sponsored by Zuckerman Future Technologies. Their REMI laser is a Class 4 laser for professionals. It's different from anything available on the market in that it is a lightweight, 4 pounds, and compact but powerful device. Its large touchscreen makes it easy to use, and the multiple wavelengths, 650, 810, and 980 nanometers, power variables up to 30 watts, and the safety rating make it optimal for many conditions, including the effective and pain-free treatment of soft tissue issues such as plantar fasciitis and Achilles tendinopathy, peripheral neuropathy, neuromas, arthritis, onychomycosis, warts, and more. It is the only laser with FDA 510K approval and insurance coverage. Zuckerman Future Technologies was built to focus on quality products and excellent customer support. When you join the REMI family, you will receive one-on-one training and ongoing support. Zuckerman Future Technologies deals with all aspects of the REMI in-house, and this keeps out the middleman, which allows them to offer this revolutionary device at a 40% reduced price compared to anything that can provide the same or similar results. In addition to this, Zuckerman Future Technologies provide a comprehensive, well-rounded marketing platform that includes customizable brochures and posters, in-office educational videos for your patients, as well as web page and hard copy ad templates. There are currently over 700 REMI users in the United States and Europe, and those numbers are rising every day. Learn more about this fantastic product and join the growing number of professionals who are benefiting from having the REMI in their practice. I personally implemented the REMI laser into our practice about 4 years ago, and I cannot say enough about the utility, versatility, and efficacy that I have seen with this technology. I also can say that of all of the capital equipment that I have purchased, and trust me, it's been a lot over the last 36 years, this is one of the best expenditures I have made. Zuckerman Future Technologies is offering the listeners of the Pod of Inquiry a really great deal. You'll get a $1,000 cart for the REMI laser when you use code 007. That's right, a $1,000 REMI laser cart for just the bona fide Pod of Inquiry spelunkers. You can go to the website, remilaser.com, and use the code 007.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show, if used personally or professionally. It is the responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.